A very good afternoon to us all and a very warm welcome. My name is Kevin Hyohu. I work at the National AIDS Control Council as the Program Officer Research Hub, and it is great to have you all on board. We bring you a webinar today, courtesy of a couple of partners that we have on board. I will be letting them introduce themselves shortly. But just to give a bit of a background about what this is and what we do, these are Maisha Maarifa webinars. And what we do is we like to provide a platform for our partners and other researchers to connect with their audiences and to share findings from research that they have conducted. And the aim here is to provide the audience and hopefully influence the programs that we undertake in the country and to influence policy. So very warm welcome. I will jump straight to introducing, or rather to letting our panelists of the day introduce themselves and tell us a bit more about what they do before we get into presentations. So to our panelists, a very warm welcome to you. You may go ahead and introduce yourselves.
All right, so thank you very much, Kevin, and we're really delighted to be in this webinar. We're looking forward to a very engaging session. So my name is Robinson Karuga, based at LVCT Health. LVCT Health is a Kenyan non-profit NGO that seeks to address the most marginalized communities, with regards to addressing the most pressing health issues. And we do that through research, programming, and policy advocacy. So I will invite my fellow panelists to introduce themselves. Meanwhile, Kevin, I'm not able to start my video, but you can please enable me. But in the meantime, let me invite Florence to introduce herself.
Thank you so much, Dr. Robinson Karuga. So my name is Florence Wakesho. I work for the Ministry of Health. I am the Schistosomiasis and soil-transmitted helminths focal person. Thank you.
Thank you, Florence. Our next panelist is Dr. Victoria Gamba.
Greetings all. My name is Dr. Victoria Gamba. I am a reproductive health specialist doing my residency at the University of Nairobi. Also partly involved with the Ministry of Health under the Fgs study. Thank you.
Thank you, Dr. Gamba. Our next panelist is Felicia Wong.
Hi, everybody. My name is Felicia Wong. I'm really happy to be here today. I'm the head of innovation at Frontline AIDS. Frontline AIDS is a UK-based organization, and we work with partners in around 40 countries, and LVCT is our core partner in Kenya, and also working together around an FGS integration coalition, which I'll speak to a little bit later. Thanks, Robinson.
Great, thank you. Last but not least, let me invite Isis.
Thanks, Robinson, and welcome, everyone. I'm Isis Molino. I am a nurse from Brazil and a global health specialist, and I'm working together with Bridges to Development, a nonprofit that seeks to advance resilience in communities on path towards sustainable development, and also Frontline AIDS. Together, we are building a coalition for FGS, but we will be talking about this shortly. Thank you.
All right, excellent. So those are the panelists that we'll be hearing from today, this afternoon. And the work that we're going to present is titled Leveraging the Experience of Community-Based HIV Prevention Responses for Increasing Awareness and Demand for Female Genital Schistosomiasis Prevention, Diagnosis, and Treatment. So this is an implementation science research that was conducted in partnership, in collaboration with the Ministry of Health, specifically the Division of communicable diseases and NTD unit. And we also partnered with the Homa Bay County the Kenya Medical Research Institute. And the other partners that were involved were, of course, LVCT Health, Frontline AIDS, and the Schistosomiasis Control Initiative Foundation. And we did this with support from the core NTD program. So in the next 1 hour or so, we've introduced ourselves, and considering most of our participants in this meeting have a HIV background. So we're going to give a brief overview of schistosomiasis and female genital schistosomiasis. Then we're going to present findings of a pilot project that sought to integrate female genital schistosomiasis education in an ongoing community HIV prevention program. Then finally, we're going to introduce a global coalition on female genital schisto that was started in the course of this project. So some of the key outcomes or objectives from this meeting, and of course, we're just kicking off the conversations, we'll be sharing the outcomes of an integration project that we did. So this, we share the lessons that we learned. We also want to establish or start conversations on how we can establish innovative partnerships between neglected tropical diseases and HIV, because in most cases we've seen most of these conditions are endemic in the different geographic locations, and discuss how we can start leveraging on HIV and other reproductive health platforms to increase understanding for FGS prevention and control. So let me hand over to my colleague, Florence from the Ministry of Health, to just give us a broad overview of neglected tropical diseases. Florence, please unmute.
Oh, thank you for that. Thank you. So WHO has listed 20 neglected tropical diseases, which is within the Ministry of Health, the Division of Vector-Borne and Neglected Tropical Diseases, to ensure that some of these infections we are able to control or possibly eliminate in Kenya. So as you can see from the diagram, we are having 4 kinds of infections. You have protozoans, virus, bacteria, and also the helminthes. So for today's discussion, we are going to be speaking much about soil schistosomiasis, which is one of the parasitic infections in Kenya and globally. So schistosomiasis, probably if we can move to the next slide, please. Schistosomiasis is a tropical disease caused by a blood fluke called schistosoma. It affects averagely around 240 million persons worldwide. These parasites, they live, or the worms rather, they live in the freshwater bodies, and they affect majorly the poor communities, which usually have inadequate clean water or inadequate sanitation, and also probably are not able to get medication or treatment. So these factors put them at a high risk of getting these infections. So here we are speaking majorly of 2 types of species in Kenya, but globally we have Schistosoma mansoni, which geographically is found in Africa, Middle East, Caribbean, Brazil, Venezuela, Suriname. And then we have Schistosoma japonicum, we have Schistosoma mekongi, Schistosoma juninensis, and intercalum. So majorly in Kenya, we have Schistosoma mansoni that transmit intestinal schistosomiasis. And when it comes to urogenital schistosomiasis, we have the species Schistosoma hematobium. So these are the ones that are found majorly in Kenya. So usually in Kenya, we have at least or estimated 9 people who are already infected, and around 17.4 million people who are at risk of getting this infection. So ideally, the infection, if you look at the transmission cycle, I'll not speak a jargon of so many words or a lot of science in this. I'll try to keep it simple. But this cycle really is telling us about the transmission cycle. So it is people who are infected. When people are infected, when persons suffering from schistosomiasis contaminate the freshwater bodies, depositing the eggs through feces or urine. So these eggs develop and mature into larval forms that penetrate or burrow through the skin. So these larvae will migrate through the venous system, through the heart and the lungs, and within several weeks, the parasites will mature and produce eggs. So these eggs of these parasites will migrate to the bladder or intestine, or the intestine, where they will be passed either through urine or feces. So some of the eggs ideally will be trapped within the tissues, hence affecting organs in the body. So remember we discussed about, or I introduced Schistosoma mansoni and Schistosoma hematobium being the prevalent species in Kenya. You realize that Schistosoma hematobium tends to migrate, the eggs tends to migrate to the larvae, to the bladder and release eggs in the urine, hence causing urogenital schistosomiasis. While Schistosoma hematobium, the eggs will reside within the intestines and release eggs through the feces. And this is the one that contributes to schistosoma, intestinal schistosomiasis. So in a nutshell, we have these two types of schistosomiasis that are common in Kenya. And actually the symptoms, just the general symptoms, once a person is infected, that is probably between 1 or 2 months of infection. One of the things is that you might experience a fever, which usually we call it catamar fever or chills. We have muscle aches. An individual can stay for a long time, probably with these infections. Or if these infected persons are not treated, then again, you can get chronic manifestation. And this is what is now bringing us to this discussion about female genital schistosomiasis in this particular form. So the link between schistosoma and HIV, studies have shown that schistosomiasis can be considered to be a risk factor for HIV infection, especially in women. This is because studies have shown that women of this reproductive age, or generally women who have FGS or female genital schistosomiasis, have been recorded to have higher proportion of HIV receptors within their genital tissue than those that are without female genital schistosomiasis condition. So it is with this that we felt it was good for us just to give a background for the audience to understand what schistosomiasis is, just to understand that it is among the neglected tropical diseases that has been noted by WHO and marked for elimination by 2030 globally. But within Kenya, we are looking at eliminating this disease by 2023 through breaking transmission strategy, which in the other slides, I'll be able to discuss more on that. Thank you.
All right, thank you, Florence, and I will hand over to Dr. Victoria Gamba.
Greetings, everyone. I hope you can hear me. So let's dive into the main topic. So what is FGS and why is it important to integrate FGS now? So if we look at the global statistics, the WHO, in 2019, it was estimated that there were 236.6 million people living at risk of acquiring schistosomiasis, 90% of which were in the sub-Saharan region. And out of this number, 33 to 75%, which is approximately 56 million women and girls, were vulnerable in getting schistosomiasis. Next slide. So next slide, please, Kevin. So why is it that we're talking about schistosomiasis now, having the first case in 1850, yet we know so much, yet so little about it? So can we move to the next slide, number 7? Yes, so this is just a brief overview of the life cycle of schistosomiasis. My colleague, Florence Wakesho, has been able to talk about it. On your right, you can see the diagram. There's a lot of emphasis on the life cycle outside the host and also inside the host that we know so much about. Now, what we need to know is now what exactly happens in the definitive host. And that's where I want you to get into. Next slide. So now once the schistosomal carrier penetrates the skin, it now becomes a schistosomule, and then now it goes into the circulation. As you can see on the diagram on the right side of the slide, you can see the adult worms in the portal circulation, the extreme right, as they are going now into the pelvic venous plexus, into now the various organs that are in the pelvis, including the rectum, the uterus, the fallopian tubes, the ovaries. You can also see the bladder at the front. Now, this brings about now the definitive definition of FGS. So basically, in essence, it refers to presence of schistosoma hematobium eggs or DNA in the genital tract. This can also be seen by when you do a visual exam, you're able to see the 3 pathognomonic signs of FGS, which we'll get to as we go along. Next slide. So we also have MGS, which was first described by Professor Madden in 1911, when he noticed that there were some young men who used to come with swollen scrotum, and they usually was painful, and it was associated with blood in the sperm, in the semen. So now it usually presents with the following: pain during coitus or during ejaculation, and also discomfort during erection. Some of them also may present in the late sequelae of the symptoms with subfertility. So, and also by inference, there's no causality, direct causality of FGS and HIV transmission, but it is seen that the presence of the inflammatory cells within the semen and everything predisposes them to HIV infection. Next slide. So in terms of female genital presentation in the women, among women and the clinical presentation, so it's usually very non-specific. And most of the time you require detailed history to actually elucidate the exact cause of some of the symptoms that it presents with. For example, the women might come with vaginal discharge, which is usually either whitish or bloody. And then some of them may come with bleeding following intercourse or spotting. Some may have genital itching, some may have pelvic pain, or even blood in urine. However, it's also good to note to actually elucidate the history of contact with freshwater body. So next slide. So in terms of diagnosis, we say usually on visual examination, we usually have some of the 3 pathognomonic signs of FGS that usually gives you a probable diagnosis of FGS. Of course, we know histopathology or isolation of the egg in itself and of the schistosoma egg is the definitive diagnosis, but this one's a probable diagnosis of FGS. So the main ones are what you can see on the slide, the raised papules that look a bit whitish to yellow. So those are the rubbery papules that you normally get. You can see some of the discoloration of the blood vessels. They look red, but they're a bit more branched around there. Then in some areas, you can actually see grains of sand. We call them yellow sandy patches, grainy sandy patches. Or sometimes instead of having the grainy appearance, they just appear as a homogeneous area, which is yellow. So next slide. So we do know that there are some complications, of course, when you have female genital schistosomiasis. So some of them might be in the short term. However, most of them do appear in the long term because FGS is usually as a sequelae of chronic infestation of schistosomiasis. So of course, during examination, you might have a patient presenting with bleeding during examination. And then now some of the long-term sequelae, they may present with subfertility, especially when they get peritubular lesions or even granulomas forming within the tubes. And then some of them may also present with ectopic pregnancies. Similarly, they may also get urine symptoms, especially if the bladder is involved or the mechanism of the urine passage. So they may have even stress incontinence. They can also present with genital ulcers and of course with chronic irritation of the skin. They may develop into swellings or tumors of the vulva or the vagina. So other complications that we know, of course, when they do get hematuria or bleeding, they tend to get anemia, which now has a long-term effects in terms of learning difficulties and also stunted growth. So next slide. So how do we prevent FGS? So that's the question, and that's exactly why we're all here, to try and see how we can use our concerted effort to this aim. So first and foremost, most of the time, we do have primary prevention that mostly starts at the community level. So this is what you're trying to aim at, increasing awareness in the community about the FGS risk and how you can acquire it and the impact. And also now, what measures can you use to avoid now schistosomiasis infection? That is, of course, avoiding contact with water infested areas. And then also, as the healthcare workers and the policy makers, we do the mass drug administration. Then also, as a secondary prevention, definitely is early case identification, and then you treat, and you treat every person and do contact tracing for the rest. Next slide. So what are the public health implications of FGS? So if we look at the diagram on the left side of the screen, it shows a woman with a bucket, probably just going about her normal domestic chores. And then now, once she gets FGS, you can see the kind of turmoil she's in as she's trying to figure out how to go to, or rather look for healthcare or to seek for healthcare service. Usually, if we use a 3 delay model, this is usually one of the first delay that we get. Usually the women take time before they decide to actually seek healthcare. Usually because, the presentation is, abnormal discharge. It could be confused for STI, and, the stigma the lady will face even just going to the healthcare workers, or even just telling the spouse that she has abnormal discharge. That could also bring about marital discord. So that's usually one of the first delay. So by the time now she gets help, she decides to go to the local dispensary. You can see she goes to the first one in a motorbike. And then she describes the symptoms, she's given medication, but it still doesn't work because, of the non-specific presentation of FGS. So she still has to go back again to another hospital. Most of the time, either they don't have the facility to do that, or maybe they tell you it's a HIV clinic, or it's a family planning clinic, or an antenatal clinic. So everything are a bit disjointed. So by the time she actually gets to the care at, she presented as D in the tertiary facility, you can understand the kind of journey she has had, and probably also some of the irreversible effects of FGS that she may have. So as we've said, FGS remains undiagnosed in most cases, and we know there's some association with HIV and AIDS and also the HPV infections. So next slide. I'll hand over to you, Isis.
Thanks, Victoria. So we have all this story about FGS, but let's dive a bit in on the evidence. So what we have here on figures A, B, C, and D, they illustrate the overlapping geographical distributions of schistosomiasis infections and HIV prevalence, reported case of FGS and infertility. And although the risk factors, HIV and schistosoma hematobial, are different, these two conditions share a substantial geographical overlap, as you can see on figure A and B. In addition, schistosoma infection in women, and more specifically, female genital schistosomiasis, has been associated with prevalent HIV infection. And moreover, the distribution of secondary infertility, meaning infertility after giving birth to a child, overlaps substantially with the distribution of FGS, indicating possibly an association with this reproductive issue and this parasitic disease when you see figures A and D. Please, next slide. Well, but what this means specifically to Kenya? To the best of our knowledge, there is no study proving the association specifically in Kenya, but evidence of other study locations indicate that schistosoma infections were associated with increased transmission of HIV from both sexes, acquisition of HIV in women, and increased progression to death in HIV plus women. Next slide, please. But how this association is described? So on the right, there is this conceptual pathway that reveals several hypotheses for how FGS may influence mechanisms of associated HIV acquisition. So in other words, we are trying to explain this question. Does FGS behave like an STI or bacterial vaginosis in heterosexual HIV acquisition? So the red arrows illustrate well-described relationships between mechanisms associated with HIV. We have STIs, vaginal inflammation, and non-optical cervical vaginal microbiota. And those are well-established mechanisms to enhance HIV susceptibility. It seems, and then you look to the dashed arrows, that FGS also contributes to all those factors and therefore may enhance HIV susceptibility. However, more research is needed, but all indications point to this direction. Next slide, please. Another important consequence of FGS is infertility. And infertility appears to be associated spatially with S. hematobion prevalence. And this exploratory spatial study from Woodall et al. Showed that infertility was not spatially random in Kenya and mapped the clustering of infertility and its co-location with schistosomiasis. So if you look to both maps, you see on the southeast region of Kenya that there is a high prevalence of S. hematobion. And on the other map, more on the right, you see the map association is high for S. hematobion and infertility. Now I give the floor for my colleagues. Thanks.
All right. Thank you, Isis. I will hand over to Florence.
Yeah, thank you, Isis and Robinson. So I'll take you through the integration of FGS and HIV. So we have documents that have been documented in aligning with the strategies to ensure that we are able to control these infections. So one of it is no more neglect, which talks about female genital schistosomiasis and HIV. This document was launched by WHO and UNAIDS, just a call to integrate female genital schistosomiasis in women health services, health interventions, including social and mental. And then in line with that, we have a strategy that is also running from 2021 to 2026 on end inequalities and AIDS that is adopted by the UNAIDS program which highlights the importance of integrating schistosomiasis and HIV. So this is end inequalities and AIDS, global AIDS strategy. So we have the other global document by WHO that is ending the neglect to attain the sustainable development goals, which is a roadmap for neglect tropical diseases 2021 to 2030. So above that, nationally in Kenya, we can move to the next slide, please. Thank you. In Kenya, we have the Kenya Breaking Transmission Strategy that was launched by the Ministry of Health. That runs from 2019 to 2023. the main goal of breaking transmission strategy is to be able to stop MDA, that is after sufficient reduction of this infection, especially schistosomiasis that is in question in this discussion today. So we have a number of lines of strategies that we are looking at through the breaking transmission strategy. One of it is to increase MDA coverage in all endemic regions. What this means is all endemic regions where schistosomiasis is prevalent. By doing so, we'll be able to reduce the threshold or the virulence of the disease, and so be able to reduce the infection within the community. Secondly, we are looking at expanding NTD-related wash and interventions. So we realize schistosomiasis is amenable to water, and because water, sanitation, and hygiene, and because water is not within the document within the Ministry of Health, it lies within the another ministry. We are looking at working closely with partners and also the line Ministry of Water and Sanitation to be able to put interventions in place that will be able to provide or improve sanitation and provision of water, clean water to the community. So here we are looking at coordination aspects, really to be able to work with the other partners, to be able to synergize the energies so that we are able to improve these two situations within Kenya. The third is to intensify advocacy, coordination, and partnership in NTD control and elimination. So this means that as NTD, we are looking at working very closely with our partners. Coordination, we are looking at working with our donor partners, the ones who provide us with medication like the MAC, who provide praziquantel, that is which is a cornerstone for treatment of schistosomiasis. We are looking at partnership like LCBT in the HIV. We are looking at partnership and collaboration with other line ministries like Malaise Bora and others like malaria, just to be able to control and reach our elimination goals. The other one is strengthening system for monitoring, evaluation, surveillance, and research. We realize that for us to be able to attain our elimination goals, we need to continually be able to monitor progress and evaluate our situation. As much as we are doing treatment and getting mapping for the areas that we need to treat, as much as we are doing interventions, we need to monitor our system so that we are able to ensure that we reach our elimination goals. So fifthly, resource mobilization for sustainability of NTD program. So we realize this is a neglected tropical disease. Much attention is not being given probably from the line government ministries. So we require a lot of partnership and to be able to resource mobilize, working with the counties very closely for them to be able to come in and be able to take up the gains that already, the activities that we have started, for them to be able to put budgets across the activities that we are putting right now as a line ministry, so that for sustainability purposes. So what else probably I would want to add on sustainability of the NTD program is to ensure that we are having a continuous behavior change communication, just to ensure that we are able to sustain the gains that we have will achieve through probably mass drug administration, which is one of our cornerstones for control and elimination of schistosomiasis. So in a nutshell, that is all about the breaking transmission. So we are looking at eliminating this disease by 2023 in Kenya, but globally we are looking at elimination at 2030. By 2030 globally, but in Kenya, we have a high vision to ensure that we are able to eliminate this condition by 2023 with the intensified efforts or comprehensive efforts that we have listed here. Thank you.
Yeah, thank you, Florence. I'll continue the next strategy by the WHO. This came about in terms of trying to break the silos in the different spectra that we have. So we know we have various intervention programs in the FGS field, in the HIV spectrum, and also the cervical cancer screening. This is not too busy, but I'll try to simplify it for everyone, because this is exactly why we're here. because we're all from different backgrounds, and you want to actually make sure by the end of this, you actually know what your role would be in terms of the integrated approach to FGS. So if we start from the left side, so there are various strategies, especially in the schistosomiasis and FGS spectrum, and most of them involve at the community level, at the healthcare worker or the training level, and also at the policy level. So if we start on the extreme left, there are various strategies to ensure that we give regular praziquantel, that's usually the mass drug administration, and also strategies to improve awareness of female genital schistosomiasis at the community level. And at the extreme right, the boxes, we also have community level burden assessment of female genital schistosomiasis. We also have clinical protocols for established FGS that we can use. The WHO has a very good manual on that. Then we also have impact and economic evaluation of the strategies. This can happen in all the spectrum that we've put. So in terms of cervical cancer, we know we have routine screening for either HIV or those without HIV infection, but any woman is supposed to have regular cervical cancer screening. Either you can use the HPV or pap smears. And also for now, we are really advocating for vaccination for boys and girls under the age from 9 years to 13. So at this interactions when we have with our patients, these are some of the areas that we can actually use to actually screen also for FGS as we are screening for cervical cancer. Then in the HIV group, usually we advocate at least one testing per person in their lifetime, or depending on their risk state. If they engage in high-risk behaviors, then it may be more frequent, or even for women who are pregnant anytime at first contact, you must do HIV screening. So it is at this point that you also, as you're looking for your screening for HIV, you can also ask about FGS or their contact with freshwater body, and also do screening for schistosomiasis. Also at the same time, we also try to do screening for the STIs in the HIV spectrum to prevent and also screen and treat at the same time. So in that same docket, that's the time you're supposed to also try and also ask about their contacts with freshwater body, and also now also screen for FGS in the same sitting. Remember, all this it's one woman and all these many approaches. So you try to give them as much as a person-centered approach, so that we can be able to integrate the care and the treatment and also early referral for the patient. So in a nutshell, if you look at the most middle part where all the circles are joining, you need to integrate, and then you have a people-centered care and offer treatment and referral, appropriate treatment and referral for the patient. And also for the healthcare workers, ensure you have adequate training and support in terms of equipment that you need. And then create gender and youth-friendly services, and also community engagement with also anti-stigma strategies. So basically, in a nutshell, that is the gist of this whole presentation. Thank you.
All right. Thank you very much, Dr. Gamba. Yeah, so in the next in the next segment, we're going to look at how we integrated HIV, how integrated schistosomiasis and FGS interventions in an already existing HIV platform. So at the beginning of our intervention, we just did a quick scoping, and we observed that a lot of the interventions that target the same population, who will be adolescent girls, young women, and even women of reproductive age, were quite siloed. So for example, HIV prevention, care and treatment interventions would happen in one silo. Sexual and reproductive health interventions, including cervical cancer screening, would happen in another silo. WASH interventions, another silo. So in our implementation science approach, we set out to pilot the outcomes of integrating all these interventions that target the same populations through health education, creating awareness, and capacity building. And of course, our motivation was to align ourselves with the global strategies, like the one we just heard about, the UNAIDS global strategy, which really recommends for the integration of FGS into HIV interventions, because as we had earlier on, there is an association between FGS and HIV transmission. We also wanted to align ourselves with the objectives of the Ministry of Health, which have been captured in the Breaking Transmission Strategy. So we did this study, we did this project in Homa Bay County. So the piloting was in one ward, which is called Gamba ward. And just some background information, we looked at the overall the HIV prevalence within the county, which was at least 18.5%. And of course, there were pockets of different populations who may have a higher prevalence, or the key populations. And then we also did a literature review to look at the prevalence of HIV in the region, and also looked at some of the surveillance data, and published literature about prevalence for schistosomiasis ranged between 10 to 29%, and in the study that we looked at mainly focused on school-going children or school-aged children. But of course, using county surveillance data, some pockets had higher prevalence, say water ponds and around some areas along the lake. So we implemented this intervention in community sites where we partnered with community health volunteers, safe spaces within the DREAMS program, which I'm going to talk about in the next slide, and of course in the primary health care facilities. So this study is ongoing. So we'll go on until November of this year. But, the remaining part of the project is just reporting and conducting a lot of advocacy using the evidence that we've collected over the last 1 year. All right, so now this is a platform where we embedded or we integrated FGS health education and sensitization. So the DREAMS program is a very big project that's funded by PEP facility across several countries. So LVCT is an implementation partner in the DREAMS, implements the DREAMS program in Homa Bay and also Migori, but here we focused on Homa Bay. And the main objective was to prevent new HIV infections and prevent unintended pregnancies amongst adolescent girls and young women who are aged between 10 years and 24 years. This program also targets school-going children. Now, amongst the many or the different interventions for preventing HIV and unintended pregnancies amongst adolescent girls and young women, we focused on 3 components, where the first one was safe spaces, where the adolescent girls and young women are able to receive HIV testing, STI screening, education about pre-exposure prophylaxis, condom distribution, and a host of other HIV prevention interventions. So we embedded or integrated FGS interventions, like sensitizing them about schistosomiasis and FGS, and also referring, any of our clients who had the symptoms would be referred by the mentors, who are girls and young women that we work with within this program. Then we also embedded our work around the community health strategy. So as the community health volunteers visited the households and they spoke to the girls about, delivered health education. So over and above the HIV and SRH education that they provided to the adolescent girls and young women, they also, asked for whether somebody in a household has experienced symptoms of FGS or schistosomiasis, provided education about schistosomiasis and FGS, and referred our community members to the primary health facilities. There were also, although it was quite diminished because of the COVID-19 pandemic, we diminished the community outreaches because they entail huge gatherings. But in the smaller groups where the DREAM mentors and the CHVs met people, maybe in their facilities, they would also integrate FGS and schistosomiasis education wherever they reached out to the community members. So the objective of our study, they broadly wanted to integrate prevention, diagnosis, and treatment of FGS in community-based programs, including the DREAMS intervention. So we set out by first assessing what do community members know, what are their attitudes, and what are their practices around FGS. So we also targeted primary health workers in this survey. So then after that, after the formative stage, we assessed the effects of integrating HIV education amongst the health workers and the target populations in the DREAMS interventions, including community health volunteers or the community health services. Then now, at the moment, we are currently assessing the feasibility of training health workers on FGS. So this is just a summary of the different phases of the study. So the formative stage or the formative phase is where we just got the exploratory. We got a situation analysis of what people know about FGS and schistosomiasis. Where do they seek help? Would they seek help? Then using this evidence generated during the formative stage, we co-developed with the community members and the health workers in a very participatory way, co-developed strategies and materials that we used during the implementations of the various interventions. So right now, we are currently in the third stage, and the data is still being analyzed. So to develop the formative, or to develop a situation analysis, our survey was conducted amongst 379 community members in our pilot site. We also collected qualitative data just to know what people do, or what people know around FGS. Then we are currently in the implementation phase, and as we are moving along in the month of August, we did a very quick analysis where we targeted health workers, community health volunteers, and program managers, just to find out what are the outcomes of integrating these interventions. So we'll be able to present more comprehensive findings by the end of this month. All right, so I'll give a very quick background on what we found in the formative stage. So in terms of awareness, because our study site had gone through a number of series of mass drug administrations by the Homa Bay County and also the Ministry of Health and other partners. So there was some awareness about bilharzia or urinary schistosomiasis and the symptoms, but then FGS was largely unknown. So our focus in this particular presentation was mainly more on the integration, and we'll get another forum to discuss more the findings in greater depth. But I'll just proceed to just give more detail about how we went about integrating the different interventions, or the health education and awareness interventions. So I'll start by presenting our integration in the safe spaces. So safe spaces are places where the girls meet with their mentors and they receive education and HIV interventions, and we embedded education on FGS and schistosomiasis. So through these forums, we're able to reach approximately 1,600 girls across 23 safe spaces in the world where we delivered these health education interventions. And we also targeted girls in primary schools in that area to deliver that information. So safe spaces provided a very good avenue for integrating these particular interventions. Then we also partnered with the Community Health Services Department in Homa Bay County, where we also sensitized the community health volunteers on female genital schistosomiasis. We also added a component on male genital schistosomiasis. And one thing that I would say here is the community health volunteers and the community leaders were really involved in developing the content. So there was a lot of co-production in the whole project, and we also validated all the sensitization materials with the community members, and we'll be happy to share some of these products as we end this project. And really, by the end of the day, they felt that they owned these particular materials, and they're currently using them as we move along. So here we trained 61 community health volunteers. And in other settings, they're called community health workers, and they have different names in other settings. And yeah, so we trained them using very participatory methods. Then another area that we focused on was integrating female genital schistosomiasis content, in cervical cancer screening manuals. And we did this because in the formative stage, we realized there was very little knowledge about FGS, especially amongst health professionals that were involved in pelvic examinations. And a lot of the symptoms that our health workers were seeing were constantly misdiagnosed as STIs, or there was just presumptive treatment, and a lot of antibiotics were prescribed, but we'll talk about that in the next few slides. So we reached health workers in 9 facilities in that area, and also trained health managers in Beta sub-county, the sub-county where we did this implementation. So we also used vernacular radio, and it was interesting. We thought the vernacular radio would be localized in Homa Bay County and the surrounding counties along the Lake region or Western Kenya, but we got people calling in from very far counties across the country. So as far as, for those who are familiar with the Kenyan context, would get call-ins from listeners all the way in Mombasa, in counties such as Nakuru, and of course, our predominant listeners were in the Western region. So it was a very interesting observation that we made. So we are working with the radio station to track the reach, the exact number of people that were reached with these messages. So some of the resources that we co-developed with the health workers, with the program managers in Homa Bay County, and also with the community members themselves, the community health volunteers themselves. So we developed a training manual that can fit in a handbag of a community health volunteer or a rucksack, and something that can withstand the weather elements as they go door to door delivering these services. So we developed and validated the training manual. Also developed a toolkit that they can carry also as they go from door to door, offering household services. We also developed training content that will be embedded into training manuals for cervical cancer screening, and even pre-tested this content in the health facilities within Gamba ward in Homa Bay County, where we piloted this study. We developed community posters together with the community members, and they gave us advice on the best language to use, the best phrases that we can use, and what people identify most with in that community. And of course, now we printed the FGS Atlas, a resource that was developed by the World Health Organization. We supported health workers with posters, and also the booklets that they can use in the referral rooms or the consultation rooms. So just a quick snapshot about what we found and what informed our intervention from the formative stage. So initially we found there were very high levels of stigma in the community settings. So we found situations where young women or adolescent girls would always seek services, thinking that it would be there were STIs, and they would keep getting asked why do they always come with STIs to the health facilities, and instead of not bring their sexual partners? Well, in real sense, some of them were not sexually active. So there was a lot of stigma. They felt a lot of stigma, both at facility level and also in the community level, and they could not divulge some of this information because they would be in trouble, Then there were also high levels of FGS also amongst the health workers. So a number of them had not gotten refresher training on FGS specifically. So some of them knew a bit of schistosomiasis education from what they learned in college or medical school, but had not undergone any refresher training, considering that they were in an endemic area. So there are also reports, through our focus group discussions and our interviews, there's quite a bit of misdiagnosis of FGS and schistosomiasis, where there was blanket treatment with antibiotics for anybody who presented with symptoms, like the ones Dr. Victoria mentioned earlier, like discharge or irritation or itchiness or bleeding. So there was a lot of prescription of antibiotics and also self-medication. People would walk to local pharmacists and buy drugs and administer themselves, hoping that they would treat the symptoms that they were experiencing. So there was also quite a bit of self-medication. People would use herbal regimens, boiled herbs, hoping that they'll be able to treat the symptoms. So as we are moving along, we are still looking at some of the data, but the early data that's coming in, we are seeing, from the health managers, they are perceiving this integration as feasible because they don't have to hire different or supervise different teams doing different things. So when health workers are sensitized together, on FGS, they're able to create a one-stop shop to address all the comorbidities in the area. From our dream mentors and our community health volunteers, and even our community members, they reported that they were now more aware about some of the facts about schistosomiasis and FGS. And they reported that now they would be more willing to take up referral and beat the stigma. So of course there were a lot of myths and misconceptions about how bilharzia is transmitted, and which also fueled the stigma. Again, we saw, we've done this piloting over a few months, so it is still, it's a very slow process, but we will get there eventually. As much as our participants viewed it as possible or as feasible, they reported that it needs time. It needs time to, to become a culture amongst the health professionals and amongst the community health volunteers. And of course, in the fourth slide, we observed, sorry, the content is not there. We observed that during the micro teaching sessions in the facility level, our health providers are also making attempts on specific days when there are clinics within the facility to provide education about schistosomiasis using some of the information and education materials that were provided, that we co-developed. So we're just reflecting on some of the lessons of what worked. So the first one was the coordination between the Ministry of Health and the county government really contributed to some of the successes that we are still analyzing at this point in time, because we made sure that we are aligning the work that we're doing here with the strategy. So whether it's a breaking transmission strategy or the county government strategies, so that we found was contributed to the positive effects. Leveraging on the experiences that already exist. So there's a lot of experience around running HIV and cervical cancer screening programs. So adding content on FGS that may present sometimes like an STI, or maybe mistaken for cervical cancer, at the early stages, for example. So using that, we'll just add on some extra knowledge and they'll be able to provide correct services to the population that are most in need. Co-production of communication materials with targeted populations, health workers, and community members really helped in identifying where to localize our interventions and where, how to develop these materials, and it also contributed to the ownership of this content. Of course, working with community level health structures like the community health services. So instead of creating a whole new parallel intervention, work within what already exists and build on that. And we identified opportunities where we can leverage some of this additional information. And capacity development was also very crucial. So once our community volunteers, health volunteers, and primary health workers were sensitized on FGS and schistosomiasis, that really awakened their interest and integration. So my final slide will be some of the proposed recommendations based on some of our synthesis. So financing is key because we may not have sustainable interventions if we don't have enough funding, but this can be leveraged from existing opportunities, such as all the interventions that are currently being implemented as part of our health agenda within the country, such as achieving universal health coverage, so we can leverage on that, or even existing maternal and reproductive health interventions, such as Malezi Bora, which targets women of reproductive, which entails promoting equity, especially amongst maternal health care services. So incorporation of relevant schistosomiasis and FGS training, especially pre-service training, refresher training in service, and also broadening the training or the capacity development amongst community health volunteers, adding a module on schistosomiasis, and even broadening it not just to FGS, to genital schistosomiasis, because we also, male genital schistosomiasis is also a problem that is quietly it's stigmatized, and we may have men who are suffering silently with these conditions. And of course, now integration of schistosomiasis control strategies across different sectors, which may be running some of these their programs in silos. So say departments of environment, other public health interventions, or other public health programs, integration would really be beneficial. So that's a very quick representation of the work that we did. So let me hand over to my colleague, Felicia, to talk about some of the advocacy efforts for integration of FGS. So welcome, Felicia.
Hi, thanks so much, Robinson. Oh, sorry, I'm gonna make sure that. So I'm here just a couple minutes to share with you a little bit about the FGS integration group, which has been developing alongside of the LVCT project that you've just heard about. And I think one of the things that I was just completely surprised about when I heard about FGS is that, and I've worked in HIV for the last 20 years, is that I had no idea about it. And I thought it was so crazy that we weren't working on it. FGS has been known as an issue caused by bilharzia for over 20 years, but it's still one of the most neglected sexual and reproductive health issues for women, because FGS falls in between the cracks of NTD and sexual and reproductive health. So we don't treat sexual and reproductive health issues in NTD programs, yet FGS isn't widely known about or recognized as an SRHR issue. And you've heard also, I think from various speakers that various service providers and, those of us working in HIV, SRHR, cervical cancer, FGS isn't part of the training. So, LVCT, Frontline AIDS, Reproductive Development, Schistosomiasis Control Initiative Foundation, which are all part of this project, also Site Savers and Avert, are founding members of FIG, or the FGS integration group, as you can see. And it was really, it started as a group of individuals who are passionate about addressing FGS and thought really the only way that we could truly address FGS is looking at integration across NTDs, HIV, SRHR, and looking at women's health through an integrated lens. Because I think, as Robinson mentioned, women are receiving services, women and girls, from all of these aspects. So we're a multi-stakeholder partnership looking at an integrated lens, because I think there are a lot of people working on FGS from MTDs, from just different aspects, but our aim is to bring it together. And I think some of the benefits of that is really around strengthening health systems across the health system through FGS lens, looking at how we can address stigma and discrimination and gender inequality, and then just deliver really comprehensive integrated care. And when we look at FIG, or the FGS integration group, we're looking at really an innovative health partnership. These are areas of work that very unlikely that we would be working together otherwise. And actually that brings so much, actually quite a lot of excitement. So our approach around and FIG includes 5 pathways of change. They're drawn from the different strategies that Florence and Victoria discussed. We also validated this through consultation. So increasing awareness of FGS in communities among health providers and SRHR stakeholders, strengthening the evidence base for FGS integration, and integrating FGS services within NTD, HIV, SRHR, and maternal health services, mobilizing diverse stakeholders to collaborate, including private sector actors, to work differently than what we're used to, and then addressing the stigma and violence often experienced by women who have FGS or HIV or misdiagnosed as an STI, because as we know, there is so much, I think, stigma and judgments when it's related to STIs. And I think we can see from the LPCT project that the project cuts across all of these areas as well. And so we've really, we're drawing on this project as well as others to feed into the advocacy work that we're doing. And then we can go to the last slide. And we're really, we're really a new coalition, FIG integration group, and we are welcoming and looking towards having new and different allies and partners to join the group. So this has been great to see people working both in NTDs and HIV and other parts of health coming together to learn about FGS. So really, that's all I wanted to say. There's Robinson's email is on the slide. Please reach out to him if you're interested in working on FGS and also on integrating FGS within your work. And I really look forward to seeing you in an upcoming FIG meeting or event in the future. So thank you very much for this opportunity. And I'm going to now hand over to Florence.
Yeah, thank you so much, Felicia. So I'll just give it a wrap from the Ministry of Health in the Department of Vector-borne and Neglected Tropical Diseases. We want just to say that we have commendable outcomes that we have already been able to achieve in our efforts to control and eliminate the NTDs in Kenya. Some among them are through the BTS strategy. We've been able, right now we are looking at eliminating lymphatic filariasis in the coast. We are really working hard to ensure that we are able also to control and eliminate trachoma within the endemic regions. Right now we have been able to carry out mapping exercise in the coast region for schistosomiasis. And currently we are doing granular mapping in the Western County, just to be able to understand how the transmission of schistosomiasis is within those particular areas, so that we are able to do evidence-based interventions in those particular areas. So we shall be expanding these interventions throughout the country as much as we are able to get a resource to be able to map out the areas that we need to treat. So just to talk about FGS diagnosis, I know it is intrusive and quite a bit expensive, that's making it not very reachable for the resource poor endemic area communities. The burden of the disease, that is schistosomiasis, has been associated with a lot of stigma. Again, we are talking about a lot of medical complications within the people who have been affected. So this leads to a lot of decrease in productivity and also secondary health issues, which again also touch on mental issues and other complications. So therefore, it is important to ensure that we are able to quantify FGS in order to put the appropriate measures as we get towards elimination of schistosomiasis in Kenya by 2023. So within the BTS strategy, we have a coordination and a very strong coordination platform where we are working with our partners globally, national, at the county and also at the community level, just to be able to synergize within our programs, just to ensure that we are able to eliminate this disease. So this is an outcall or an outcry to all the organizations that are working probably with the reproductive health centers that you can come on board and be able to join in the coordination framework within the NTD so that we are able to fight or to able to reduce the infections of female genital schistosomiasis within the endemic counties in Kenya. So with that, I just want to say a big thank you to all the partners who made this possible. I want to mention LCVT, Frontline AIDS, SCI, Co-NTD, KEMRI, National AIDS Control Council, who are the host of this webinar. So thank you so much, and we are looking forward working together with all of you to ensure that we're able to reduce or possibly even eliminate these infections in Kenya. Thank you.
All right. Thank you very much, Florence, for that very well done closing remark. So we'll pause there and invite reflections from our participants. So feel free to type either in the chat or in the Q&A tabs, and we'll be able to respond to them. So Kevin, if you're able to direct us or where the questions that are coming up.
Absolutely. I have been tracking a couple of questions that came in, and I can be able to read those out. But perhaps before I get to that, I might pose a question on my own. I'm quite curious about how we're generally doing, right? In the presentation, there's a goal to eliminate FGS by 2023 in Kenya. So it's 2021. Is there an indication of how well we're doing? Is there some conclusive data, perhaps about diagnosis or treatment? Just some tracking that's going on that can indicate if we're on track or if we perhaps need to heighten efforts. Is there any indication?
Okay, so maybe we can take 2 or 3 questions, then we can subdivide them. But I can direct that first question to Florence. Maybe you can read for us 2 more. Thanks, Kevin.
Great. So there's a question here from Sylvia Ayon from Canco. And she says that the question I have is about the maps shown of Kenya, pointing towards the coast as areas with high infections, yet the coast generally has salty water. So she's thinking that this would be the picture for Western Kenya or areas with large freshwater bodies. So she's asking if you can please explain the variance.
All right, thank you. We can start with those 2. So maybe Florence can take up the first one, and you can also make an attempt at the second one.
Yeah, thank you so much. I'll try to, I'll attempt to answer to those questions, the first question. So within the Ministry of Health, since breaking transmission strategy was launched in 2019, we've been able to do commendable progress. So in 2019, we were able to treat community members in Homa Bay, the whole of Homa Bay and Migori, by distributing praziquantel and also mebendazole, that is for soil-transmitted helminths. In 2020, again, we had the pandemic, COVID-19, so we were not able to do much within the program. So we were able to distribute praziquantel in Homa Bay and Migori. This was informed because we have a lot of data showing that Migori and Homa Bay are very highly endemic of schistosomiasis. So that was our starting point as we were trying to expand our treatment to the community. Remember, we talked about one of the objectives of the BTS was to expand mass drug administration to the community members. So you realize we've only been treating school-going children, and as a program now we are looking at elimination goals, that means that we need to expand the treatment to other cohorts in the community, which include now also women of reproductive health. We have adults, probably male, who are in other occupations. So we have a strategy to do community treatment. So in 2019 and 2020, we've been able to do that through the Ministry of Health and support of our partners who have been able to give us the medicines. Now coming to 2021, again, we were able to revamp our activities, gearing also towards elimination, and we're able to do mapping of schistosomiasis just to understand where are these diseases at the ward level, because that is the lowest administrative level. When we're talking about schistosomiasis, it is very focal, and so we need to really put our resources together in the places where really the infection is high. So we conducted mapping, that is surveys, in the coast region, that is in 2021, just to understand which are the wards that warrant treatment and which are the wards that we do not warrant treatment, just to be able to zero in and put all our resources and interventions in those particular areas to reach our elimination goals. So as part of our progress towards that, we were able to map out at least all the 130 wards that are in the coastal region, the 6 counties in the coastal region. And from that survey, we were able to establish that we have 72 wards out of 130 wards in the coast have a prevalence of 2% and above for schistosomiasis. When we're looking about elimination goal, just for us to be on the same page, we're looking at us having less than 2% of schistosomiasis prevalence. So as a program, we started working on that, and we were able to treat around 2 million community members, that is in 2021 this year, through community mass drug administration. So in 2020, this same year, we have expanded this mapping now to the Western region, where we are looking at also, currently we are doing mapping in the whole of the Western region, that is Kakamega, Bungoma, Trans Nzoia, and Vihiga, just to establish the endemicity of schistosomiasis in this area. This will be followed by treatment. This is in November, the last week of November, or the beginning of December this year, to be able to expand again treatment to these areas. So in a nutshell, as a program, we are looking towards elimination of schistosomiasis. We've not really been able to narrow down to FGS, and that is why now it is a concern even for us, because this is a morbidity that we are talking about. As a result of schistosomiasis infection in particular individuals. So we are looking at working together closely with other partners and the county governments so that we are able to fast track and be able to manage female genital schistosomiasis in this endemic region. So for starters, when you're looking about elimination, first is to identify where is this disease and how endemic is it in these particular areas. So you realize this study was conducted in Homa Bay. The reason is because we had informed data that will help us to really narrow down to Homa Bay and see whether we can have individuals affected by schistosomiasis and having this morbidity of female genital schistosomiasis. So the starting point first is to understand the area of endemicity, which as a program now we are looking at. And then secondly is to go in now and zero down to morbidity and be able to recognize and be able to see which are the morbidity cases that are within those particular endemic regions. So I'll say it's a starting point. I think this is the first collaboration we are having with LCVT and other members just to look at FGS. So going forward, we are looking at a lot, working with other partners just to be able to reach our elimination goal. As much as we're looking for schistosomiasis elimination goal, we also want to reduce the morbidity of schistosomiasis in these particular areas. I don't know whether I've been able to really answer in a correct way, but yeah, probably if I need to expound, I can expound more.
Yes, thanks, Florence. I think it's very well captured. And maybe before I invite Dr. Gamba to talk about the clinical setting, or how FGS is viewed in clinical settings, maybe I can let me answer Sylvia's question about schistosomiasis in the coastal region. So you'd find along the coast, in the coastal region, there are pockets of fresh water ponds, where the vector snails multiply, and that's their natural environment. So when communities go there either to swim or to bathe or to do other laundries, other domestic chores in these ponds, those freshwater ponds are where they get the infection from. So that's where you're seeing, quite a bit of overlap in some of these comorbidities. Yeah, so the snail vectors do not live in the salty water, but in the conducive environments provided by the freshwater ponds that are inland, especially when you go to Kilifi County, Kwale County, and others. You will, and Florence has been doing quite a bit of mapping, geographic or spatial mapping of these particular hotspots in the coastal region. So that is some work that is ongoing that's been done by the Ministry of Health. About stigma, so we've not come across, to the best of our knowledge, we've not come across any literature about stigma reduction, especially around FGS and FGS and schistosomiasis. But what I would say is, as Florence mentioned, this is a starting point, and we can leverage on the already existing skill sets that exist in other programs, on skills in HIV, and employ them to address stigma in FGS and schistosomiasis, and even other interventions like psychosocial support. Those can also, the same skill sets can be applied to address stigma, both at community level and also self-stigma. So I don't know if Dr. Gamba, you'd have a comment about FGS in clinical settings.
Well, so far, I have not seen any question, but generally we know the non-specific symptoms that FGS presents with, and we need to be awake to the idea that FGS can be one of the differentials in whenever you're examining a woman who has sexual and reproductive health issues. So just as a take home is just to have it at the back of your mind, because what we always say is the eye only sees what the eye knows. So now that we've talked about FGS, the clinical presentation, the overlap, and also the way to diagnose it, then now this provides a very good stepping ground to actually increasing FGS diagnosis. And then in terms of the stigma reduction, as usual, this is like one of the things that we try and do to reduce stigma by just increasing awareness at the community level, at the healthcare worker level, because, most of the time they treatable infection. So this is one of those avenues we can help to reduce the stigma that it is indeed could be just FGS and it's treatable. That would be my take.
Oh, okay. Thank you very much. Let me hand over back to Kevin. You can guide us because I see we're getting to the top of the hour. Maybe you can guide us on the next steps.
Yes, sure thing. Probably before that, I see Florence wants to speak. So Florence, do go ahead. I think your hand was raised.
Yes. I just wanted to add on about the coast. We've worked a lot in the coast, and we have evidence that we have a presence of schistosoma hematobium or even Mansoni at the coast, even with the salinity. So this we were able to see in very few areas. Of course, the larger area again has been pockets of freshwater bodies, as Robinson had said. But just as an additional comment is that when we were doing our studies, we were able also to find that around Msambweni, where it's just around near the sea, that we were able to find a pocket where we found schistosomiasis in Msambweni, just some slightly alkaline water body that was these snails were able to survive. Then again, just to mention that probably we didn't mention it in the beginning, is that these are snails specific for schistosomiasis. So we are talking about specific species for survival. So you'll find we have bullinus that thrives very well and transmit schistosoma hematobium that causes urogenital schistosomiasis. the one that brings FGS into this question of particular topic. And then we have Bioflavia species, a type of a snail species that is Bioflavia that causes intestinal schistosomiasis. And this, again, you find that they have or they thrive in certain ecological zones, like in the western region, not western, in the coastal region. Mostly you'll find urogenital schistosomiasis being very predominant and having intestinal schistosomiasis being at a not very high level. When you go to Homa Bay and Migori, there we are having a mixed type of infection of both urogenital and intestinal schistosomiasis. So this is just to tell you the various and ecological zones, how they play about the distribution of this disease in this country. So different ecological zones contribute to the survival of the different species in those particular ecological zones. So it's about the freshwater body and also the ecological zone survival for this specific snails. So that is all I just wanted to add, because I had missed that in my first slide, and I just wanted to recap it for the members to understand how the distribution of schistosomiasis is within the country. Thank you.
All right. I think for me, my final comment would be in the next few months, the remaining part of the year, please look out for the materials that we'll be sharing with you all. Based on the evidence from this pilot, we developed some materials for capacity development. We'll also be holding a number of advocacy sessions with various actors to see how we can start integrating some of these integrated efforts would help in mitigating the debilitating effects of schism. Of the team is to thank you very much for your active participation, and please allow me to hand back the meeting to Kevin.
Great, thank you. Thank you very much to all our panelists for the day. Thank you for the informative presentations. I believe all our participants have learned something new, including myself, and I do have some final reflections as well, some takeaways rather. So what I've seen is that a lot of coordination and sort of multi-sectoral collaboration will need to continue or be at least heightened if we are to reach elimination goals for NTDs, and also to start new programs and to sustain the already existing programs. It's also been great to hear that there was a lot of co-production of the materials, as you mentioned, Robinson, with community health volunteers or community health workers. That always has a way of promoting ownership and sort of contextualizing materials to those particular communities that they work with. But with that, I think we are at the top of the hour. Thank you very much to our participants for the day as well, for joining in, for your questions, and we do look forward to seeing you soon on our next webinar. Again, thank you to our panelists for the day. We may leave at our own pleasure. Thank you very much.